Anybody who come to the emergency room, they have a certain problem you have to know about. And they will present the story with you for you, and you have to figure out what kind of condition they're suffering from. So this is the case. And I'll show you, I mean, if you watch some of my videos, you know how I do these. You go for the bars, right? They give you age, fine. You take it, 48 years old male. You present to the emergency department with the chief complaint of what? They give you the location of the pain. It's very important. It's a GI problem. Upper abdominal pain that began sadly 2 hours ago. So this is an acute problem. 2 hours ago. He described the pain as what? This is the character of the pain. Burning, gnawing sensation located in the mid-epigastrus. You see, they keep on giving you location right in the middle. That's where the patient is having pain, right? And he radiates towards the back. He goes to the patient back. He rated the pain at 7 out of 10 and stated that it worsens after eating what spicy food, drinking coffee, and consuming alcohol. Why am I giving you all this thing? I'm trying to confuse you. I'm trying to get you focused, but these are all buzzwords, right? Spicy food, drinking coffee, and alcohol make the pain worse. Which he has been drinking heavily, so he's an alcohol, he drink a lot for the past month. Does that give you a clue? He notes that the pain is temporarily relieved when he drinks some milk over the counter, right? Or antacids. The patient reports a history of occasional nausea, decreased appetite, and unintentional weight loss of 8 pounds for the past 8 months. He has had experience with fatigue, so you get tired sometimes, and intermittent episode of black tarry stool over the last week, but deny vomiting any blood. He has no history of prior GI issues, but report frequent. He take a lot of ibuprofen for chronic back pain. After reading this, there should be some few things that should be going through your head that you should be able to figure out what is wrong with this patient. This is his temperature, this is his blood pressure, his heart rate, and saturation. His vitals look normal to me. Physical exams, he appears uncomfortable because of the pain, right? He's clutching the abdomen, he's heading. The abdominal exams reveal tenderness in the epigastrium. I told you, right in the middle, without rebound tenderness. So there's no peritonitis or gathering, right? The bowel sounds are normal, and there's no mass or no organomegaly. Spleen and liver look normal. The patient's skin appear pale, right? But there's no jaundice. This is what the NCLEX will give you. A bunch of stuff. You keep on reading and reading, and you get tired. You have to figure out what is going on with this patient. 48 years old. He came in because of abdominal pain 2 hours ago. That's your buzzword. And then you go and figure out what is the pain look like. All this I've described telling you what's the pain. The pain character is also important. It's burning sensation in the epigastrium, and sometimes you go to the back. I told you 7 out of 10. What makes the pain worse? Well, if I eat some spicy food or drink or caffeine or drink alcohol, which I've been drinking for the past few weeks or month, and it make the pain worse. But what make it better? When I take some antacids or drink some milk. These are all buzzwords. Hold on to that. Connect to that. Figure out what is wrong with this patient. Occasionally, he may have some nausea. He has lost some weight. If he's tired, his stool a little bit darker, right? But he has no vomiting, blood, or anything like that. And he takes some chronic NSAID for back pain. On exams, he has abdominal pain. There's no peritonitis. What do you think is wrong with this patient? Who can figure out what is the diagnosis? If you know it, you can type it. But this is the problem. This is the patient. This is what you have. A long story. but I've pinpointed the buzzwords that you can put it together and you'll be able to figure out what is wrong with this patient. What do you think? This is the patient age. The pain happens suddenly, right? And it is usually burning and ignoring sensation. It can go towards the back. Okay, it's 7 out of 10. It's worse with spicy food, drinking. These are risk factors. I'm trying to lead you with diagnosis. These are risk factors for the problem. Caffeine, alcohol, when you drink, this will make it worse. This is another risk factors. You take ibuprofen. This is the way I want you to do when you see some next generation question. Don't focus on one thing. Connect the dot. I know this is risk factors. What make the pain better? I drink some milk and I take some antacids. Right? I've lost some weight. Sometimes my stool is black. I've circled them to you. Connect the dots, and you will see like all those things connect. When you examine the patient, the has abdominal pain that radiates towards the back. There is no peritonitis. The patient is not jaundice. You look pale. It tell you something. This is the way you should do next generation NCLEX question. So who connects the dot? Male, sudden, burning pain, going towards the back, worse spicy food, drinking caffeine, heavy drinking is better with antacid or with milk. I can have black tarry stool, which is a complication from it. Is because I'm on a lot of ibuprofen. These are all risk factors. What do you think is going on? I see pancreatitis. These cannot be pancreatitis because just because you drink alcohol, the presence of use of ibuprofen and then caffeine and spicy food take away the diagnosis of pancreatitis, even though both of the pain radiate towards the back, right? These things get better when I take some milk or I take antacid. This tell you this is a peptic ulcer disease, classic peptic ulcer disease that when you put everything together, you know that this is peptic ulcer disease. In order to help you, I put it together. Which of the following is consistent with the diagnosis? One, epigastric pain, pain in the middle of the um, abdomen that radiate towards the back or upper abdomen. So if this is the patient, this is the belly button, and this is the xiphoid, epigastric is here like that. And the pain is also relieved with antacid and milk. So this is another key aspect of it. And then I have black tarries too. Yeah, because I take ibuprofen. So this is where the patient is having black tarries too. He's bleeding from the ulcer, all the risk factors. He take NSAID, it's a risk factor. He take alcohol, it's a risk factor. I could have added pain is worse with what? Alcohol, spicy food, and caffeine. Those are all risk factors. You have to consider them and put it together. When you see NCLEX question, you read it and you connect the dots, guys. Connect the dot as much as you can. So these are all consistent with the diagnosis. This is all consistent with peptic ulcer disease. Same thing. Question 2. You know the strategy. Figure out the buzzword and connect them. 56 years old. It's a female. He came into the emergency department complaining of what? Severe abdominal pain. It's a buzzword. That started abruptly 6 hours ago. Another acute problem. She described the pain as what? Sharp and constant. Located, look at the location. They always have to tell you where the pain is coming from. Right upper quadrant pain. And you radiate to what? The right shoulder. Does that give you a clue? It should. She report what? Nausea, and she vomit twice since this morning again. She deny what? There is no fever, no diarrhea, no change in bowel habit. No, no, no is the way to rule out other problem. But note that the pain worsen. What makes the pain worse? When she eat fatty food. That's a clue. She has a history of what? Obesity. Risk factor. She has diabetes. She deny alcohol or use of smoking. Does this give you a clue? Look at the temperature, slightly high, right? She's still slightly tachycardic because what? Of the pain. On physical exam, she appeared distressed. She has what? Right upper quadrant. That is the key. The location of the pain will tell you what is going on with this patient. Location of the pain. What is in the right upper quadrant? Is tender over there, and then she's tender, and there's a positive Murphy sign. That's another buzzword. Another buzzword. There's no rebound tenderness is present. When you look, a white count is 14,000, a liver enzymes are normal, and a bilirubin is slightly elevated. What do you think is going on? Same thing. Connect the dot, and then you'll be able to figure it out what is wrong with this patient. 56, female is one buzzword, right? Came to the emergency room, severe abdominal pain, it started suddenly, right? Describe the pain as what? Sharp and constant. Where is it located? Right upper quadrant, right? And where does he go? Shoulder. And she vomit twice. Buzzword. There is no fever, diarrhea that she can think of, but the pain is worse with what? Fatty food. She is what? Obese, risk factors, right? She does not drink alcohol and smoking. Those are all things you connect to that, you'll be able to figure out. The answer choice will pop out like a candy, like I told you. Those are keywords when you connect them. On physical exam, she's in distress because she's in pain. Once again, pain is in the right upper quadrant with guarding. There is a positive what? Murphy sign, and a white count is elevated. How do you answer? Next generation question? The keywords will be on the first two lines. First two, three lines, they have to be a buzzword that will lead you. Look for them. When you figure out the first two lines, the keyword, any subsequent sentence should support that diagnosis, support that idea. And you can see that is how we tell story. I tell you what happened, and then the subsequent one, I'm trying to reaffirm what I've said. So as you go down, try to find things that confirm what is in the first line or first two, three sentences. If it doesn't, throw it away. That's what I mean, looking for the buzzword. I know she's a female. She come in all of a sudden and she report about what? Right upper quadrant pain. They radiate to the shoulder. That's my buzzword. As soon as I see that, I say, oh, I know what it is. That means everything I'm reading down, I'm trying to find it to confirm my diagnosis. If it doesn't, throw it away. Don't chase any rabbit. Okay. Don't put yourself in the rabbit hole. You're chasing every sentence. You're trying to confirm. So that's why you see me circling them. When you're taking the NCLEX, do that. Those are your buzzwords. When you connect them, you come up with the diagnosis. So what do you think is going on with this patient? The location of the pain, which is a buzzword, right upper quadrant, going to the right shoulder, give away the pain. Because she's a female, give away the diagnosis. Because she's obese, you give away the diagnosis. Because she has a white count, you give away the diagnosis. Because she has fever, give away the diagnosis. And this is consistent with what? Acute cholecystitis. Acute cholecystitis. And I know you guys got it. If you do that, there's no case study that you can figure out what is wrong. So what is the most likely condition the client is experiencing? You just type acute cholecystitis. Like I said, I'm not going to give you options to figure out, but you have to learn how to make a diagnosis without an option, right? And this is what I'm trying to do, try to go for the pathway. Which of the following is consistent with the condition of, consistent with the diagnosis of acute cholecystitis in this client? So you're trying to figure out what we already talked about. A right upper quadrant pain is consistent with that. You know that, right? The pain going to the right shoulder. This is like a lecture. I'm trying to lead you. These are the buzzwords and lecture bulletin. You can put it together to make a diagnosis. Radiating to the right shoulder. The pain is what? Worse when I eat fatty food. Consistent with the problem. I have positive Murphy sign. That means if you push on my right upper quadrant, I'm going to stop breathing when I take a breath. That's what it means. Positive Murphy sign. It's different from McBurney point. McBurney is on the right lower quadrant. This Murphy sign is on the right upper quadrant. When you push on it, I take a breath, I stop. What is cholecystitis and anheides? I'm supposed to have fever. Yes. If I have fever, my white count is going to go up. Yes. So this question is designed, is the way, it's not the same as the NCLEX case study. You don't need it, but this as a practice to look at the case and come up with key content, and then you connect them. So this is what we connect. These are the buzzwords you use to make the diagnosis. Therefore, this is consistent. This one, all of them are consistent with what? Cholecystitis. And when you do that, like I said, well, you can go anywhere to watch videos and master your content, but there's no brainer, right? There's certain things you have to do to learn how to do case study. And this is it's like clinical, right? Clinical, how to make a diagnosis. When you go to the emergency room, that is what you'll be asked. They'll ask you all these questions and they'll put it together. So apply it when you answer questions. Go for the buzzword, the first three lines, look for the key because that is where they'll put the money. The money is always on the first three lines because those are the chief complaint. And if you find them, try to confirm them as you go. So this is what we do. Now, just a little bit, what do you think the nurse should include in the plan of care? Is an HIDES, right? Every HIDES in the GI is easy, right? Acute cholecystitis and HIDES infection. So what is going to happen? You're going to treat it with antibiotic. The patient is not going to drink anything. So it's going to be NPO. And if you NPO, I give you fluid, right? And because it's anhydrous causes pain, you get pain medication, right? Most of these people will need surgery. I need to confirm that you have anhydrous. So you get a ultrasound of your belly. This is all consistent with what the doctor would do in terms of how to manage this problem. But like I said, I'm not giving you a full case study, just a short ones to figure out. So this is all will be included in the plan of care. Questions? Another question. This one is short, but it's also the same strategy, right? Standalone, you see some standalone short question you got to figure out. 72, male, emergency department, complain of what? Abdominal pain, buzzword, nausea, distension. If you read it for the past 2 days, this is what I mean by first two lines. This should tell you something. He is a male. He came in abdominal pain, nausea, distension for 2 days. You know it's abdominal problem. What conditions will give you pain, nausea, distension for 2 days? If you don't know, you say, okay, I know something is wrong with this patient. Let me look at the third line and figure out if I can figure this. Is this pancreatitis? Is this cholecystitis? Is this appendicitis? Then you start telling your head, okay, if I think it's appendicitis, if I read the third line, it should confirm it. It reports that the pain is crampy. Appendicitis does not give you crampy. Cholecystitis does not give you crampy. And intermittent, that means it go and come. Something is wrong. Why would it go and come, right? And it's located around the belly button. Yeah, appendicitis sometimes is located around the belly button, but this go and come. And it worsen over time. It's not going to the right lower quadrant like the appendicitis do. Then you telling your head, okay, pain, nausea, distension, cramping, intermittent pain that comes and go, and it's getting worse. Then look at the last sentence. No pass stool. I have no pass any stool or gas for 2 days. Oh, appendicitis don't do that. Cholecystitis don't do that. Pancreatitis don't do that. Diverticulitis don't do that. Therefore, what am I left with? This is how you should be thinking, right? I'm leading you to the plain diagnosis. So you're telling to your head, this is what we call differential diagnosis. 72, abdominal pain, nausea, distension, cramping, intermittent, and then it's getting worse. I have no poop for a couple of days, no gas. Why would I not poop? That is your clue. Why there is no stool and I'm bloated. Something should tell you. There is no fever. It cannot be anheides. You see? No fever, no and no vomit or no recent illness. What is the buzzword? Prior history of abdominal surgery. Another buzzword. He has a hernia repair. You check, his vitals is normal, right? His abdomen is distended. I told you this is all confirming. As you go down, look for things that will confirm it. And then what? Hyperactive, high pitch bowel sound is still confirming your diagnosis. When you palpate, he has some tenderness, and there is no guarding or rebound, no peritonitis. You get an X-ray, there's a loop of bowel with multiple that are dilated. What do you think is going on? Connect the dot. The buzzwords are your gateway to the diagnosis. The buzzwords are the gateway to making a diagnosis. How do you find them? Watch the first three sentences. When you get them, go subsequently, try to confirm it. Pick apart the case one at a time. Don't just focus on one information and you say, oh, because he has pain in the umbilical area, it has to be appendicitis, where appendicitis will go to the right lower quadrant. This is getting worse, and then you get an X-ray, a loop about everywhere. This is consistent with what? You know, the buzzword was afternoon poop, no gas, no flatus, and I'm distended and I'm bloated. That means there have to be obstruction. This is what we call small bowel obstruction. It's consistent with small bowel obstruction because of the signs and symptoms I've presented unto you. Do that, and you trust me, no case study will beat you. And when you figure out what it is, it's easy. You know the treatment, right? If you're vomiting, I put the NG tube in. If you have pain, I give you pain medication. If I have NG tube and you NPO, you get fluid, right? All those things you don't have to memorize. Don't memorize anything in NCLEX or medicine. It's our concept. When you figure out the concept, you'll be able to take care of it. And this is what we already talked about. What is consistent with this? Crampy, intermittent abdominal pain, and distension. Consistent with that. I've not been able to pass gas and stool. Consistent with that. I have history of prior surgery. That's why I have scar tissue causing the obstruction. I have high pitch, hyperactive bowel sound from the obstruction, and I have air fluid layers because of the obstruction. Watch for it. Sometimes NCLEX will try to trick you. If this is the bowel and there is obstruction here, the high pitch, this sound, high pitch, hyperactive bowel sound is the bowel on top of the obstruction. The bowel below the obstruction, there's no bowel sound. So no bowel sounds will be there. So if they sometimes they will try to track you. No bowel sounds below the site of obstruction, but the site above the obstruction will have hyperactive high pitch sounds. That is consistent with the small bowel obstruction. So all this thing is consistent with that. So what do you want to do? I already told you. You know the answer. Which of the following should the nurse include in the plan of care? Do you want them to be MPO? Do you want to place NG tube? Do you think they need IV fluid? Do you think you should monitor for signs of strangulation? Do you want to give them clear liquid dye? If you know the content, the answer choice is popping out like a candy. As usual, I told you. This is right there. They're going to put the NG tube in. So, yes, of course. If I put the NG tube, definitely you're going to be MPO. And if you MPO, you get a IV fluid. I'm going to monitor for obstruction. That is the signs of strangulation. If you MPO, there's no way you're going to eat anything. So E is out of it. This is small bowel obstruction. Questions? If you have questions, you can put it in the content area and I will address it. This is the last question. Before the last question, like I said, we have a crash course coming up this Saturday. This is where you can register for if you want to register and join us. These are the content to cover, and then you have on demand. These are adapt and crash course, few days, and increase content mastering. So this is the problem. What do you think? A 45-year-old presents with what? Complaint of frequent diarrhea. This is different. Now I have a bunch of diarrhea. For the past 3 weeks, I told you always slow down and pay attention for the first three lines. Diarrhea for 3 months. 3 months diarrhea. Why would I have 3 months diarrhea? Then I told you I have 4 to 6 bar movement a day. That's a lot. It's watery, okay? And it's loose, right? And it's accompanied by what? Crampy pain and urgency. These are all buzzwords. Don't run away from it. Put it together. That means chronic diarrhea, that is crampy, that is urgent, and then it's daily. I have 4 to 6 of them. I have to tell you more about the stool. There's no question. NCLEX cannot just run away and then try to ask you. They have to give you more information about the stool so that because GI problem, you can use just a stool quality to be able to diagnose what is wrong with the patient just by the stool quality. Therefore, I went and give you more information about the stool. He also mentioned there's blood and mucus with the stool. That is key. There's some stool that will be pale, right? That is also chronic in nature. But this one, I never say it's pale in nature. I say it's mucus and what? Bloody. There's some that will be fatty in nature, that will be voluminous. Those are all buzzwords. You don't see that in this question. So don't think about them, but don't let them distract you because I told you it's diarrhea for a long time. It's not voluminous, it's not insipid, it's not pale in color. It's what? Blood and mucus. It does not alternate with constipation. I know what I'm saying. If you listen carefully, I'm giving you a differential diagnosis. It's not alternating with constipation. Therefore, it cannot be IBS, right? It's not pale in color. It cannot be celiac disease, right? It's not voluminous, fatty in nature, and foamy. It's not what? What do you think? 60 fibrosis. I've ruled out other things I think you'll be thinking about. But these are the way you tell yourself, like, oh, this is the problem. There is no fever. He has not traveled anywhere. He does not take antibiotic. Therefore, it's not what? C. diff. You see, these are all keywords. The patient feels fatigue, probably because he's anemic, because he's been having a lot of diarrhea and he has lost a lot of pounds, 12 pounds, because there is lack of absorption, more absorption. These sentence I've given you, you can make a diagnosis just by like that. But I'll give you more information. He has anemia for 2 years. He has joint problem. That's key. He does not smoke. He has a family history of inflammatory bowel disease. That's a buzzword. His vitals look fine. His abdomen is mildly tender on the left lower quadrant. There's no guarding, no rebound. And I give you diagnostics. It's a key, right? It's anemic, and there's a in fact inflammatory process going on. C reactive protein is elevated. Fecal calprotectin is also elevated. If you put these together slowly as much as possible, and you read it, go through the case, and you figure out the buzzword, you will be able to make the diagnosis. What is wrong with this patient? As usual, 45, complain of what? Chronic diarrhea. So diarrhea is key. And this is loose too, 4 to 6 times a day. And it's crampy in nature. There's urgency associated with it. There's blood and there's mucus, right? There's no fever. I've not taken any antibiotic and I feel fatigued because I'm tired. I have a family history of IBD, right? I have a joint problem. This is key. And I have anemia. And then I have all this thing. What do you think is wrong with this patient? If you connect them, can you figure out the diagnosis? If you connect them, can you figure out what is wrong with this patient? And you can tell something is wrong with this patient. The key is all the circles I've connected. And if you connect these dots, if you connect them together, you figure out that this patient has inflammatory bowel disease because of the chronic nature of the problem. This is inflammatory bowel disease, and this is classic, consistent with Crohn's disease. It's not ulcerative colitis because the stool is not completely bloody, but this is mixed with mucus. So blood and mucus stool that has been going on for a long time. I have diarrhea, I have anemia, I have history of a family history of IBD, I have a joint problem, and I have inflammatory process going on. That is different from gastroenteritis. Gastroenteritis is basically there won't be any inflammatory process, there won't be blood in your stool. You may have diarrhea, but it's not going to last for 6 months. There's not going to be anemia. So all these things you have to like put it together, and you can figure out that this patient is consistent with Crohn's disease. So this patient has Crohn's disease. Based on that, this is what I said, chronic diarrhea, stool mixed with blood and mucus, abdominal pain that is crampy, unintentional weight loss, more absorption, I have anemia, and I have elevated CRP. These are all inflammatory process that is consistent with that. What do you think this patient needs? He need a colonoscopy to do the biopsy to make a diagnosis. They may need immunosuppression, some steroid, azathioprine. These are all immunosuppression, infliximab, and then some nutrition because he has lost a lot of weight. And so all this is consistent with what this patient would need.